Welcome back to the Atlas of Chiropractic podcast here with Dr. Cameron Beater, Dr. Jonathan Chung. Part two of our three-part series on interpretation of neck care findings in upper cervical practice. For the previous episode on range of motion, which seems mundane on the surface level, but if you go back and listen and watch through that conversation, you'll find that there's so much there. It's a really robust assessment and very rich to our understanding of function of the cervical spine. But we're going to shift gears and focus on the second of the three assessments, which is joint position error. A lot of us previously did this analog style, right? You have your target on the wall and you have your head laser, and the patient goes through the process of closing their eyes, executing a movement, attempting to relocate back to the same starting position or relatively same starting position, and then we do a series of assessments on that. So that was one I always hated doing. It was just like, man, there's no way this is like good data. There's no way that I'm accurately understanding, like what I'm seeing here. So joint position error is a really, really simple, way to measure this very accurately, which I appreciate. So I think it'd be first important to understand what is, I guess, proprioception generally. Like if we were to define that term, it gets thrown around, but I don't think a lot of folks really understand what it means. What does joint position sense have to do with proprioception? And then what is a joint position error test measuring when we perform this evaluation? So, Dr. Chung, do you want to kind of wade into the waters of this discussion?
Yeah, I'd love to. So one of the ideas that we took away probably in the early 2000s, as subluxation theory started to really evolve from this idea of everything has to be bone on nerve and it's nerve compression. And the idea of disafferentation kind of came into view, ironically, thanks to Winterstein from National. And it comes with this idea that a lot of these effects from a neurologic level from subluxation is unlikely to be nerve compression, especially when it comes to like our day-to-day patients walking in. Like some patients are going to have radiculopathy. Obviously, nerve compression is, relevant there. But the vast majority of people coming in to get checked, and the reason that we're adjusting them is nothing to do with the fact that a nerve is getting compressed. A lot of it has to do with the fact that a bony joint isn't moving very well. And because of that, there is less mechanical activation of these receptors that are getting into the brain. Therefore, the brain has a distorted perception of what is going on in that region of the body. And the way that I explain it to patients is actually straightforward. I'll have them say, like, what we're measuring here is something called proprioception, which is the idea that our brain knows what our joints are doing at any given time. Just like if I were to have you close your eyes and I had you start to move your finger in different positions, you know approximately how much your finger is bent with your eyes closed, despite not knowing what it looks like when you're seeing it. It's because you have all these sensors inside of your muscles and joints that are giving your brain feedback about how much it is being bent. Same thing that comes with this. Your brain should generally know when is your head in the center of your body, and your brain should know when your head is turned left, turned right, and the approximate degrees of how well it's able to pick that up. So previously, when we were talking about disafferentation, we talked about the importance of proprioception because proprioception feeds heavily into the cerebellum. And that cerebellar drive is what makes our brains healthy because it drives into that frontal cortex. And that's how this whole idea of like brain-based chiropractic kind of like took hold, where, Heidi Havoc's publishing a lot of research on this. But one of the main problems is we had no good ways of actually measuring proprioception. So it's an esoteric concept that we knew from a biological plausibility probably fits, but how do we actually track what's going on from a proprioception standpoint? So some physical therapists actually developed this test with joint position error. They said, well, if someone has good joint position error, they should be able to reposition their head in what they perceive as the center point, and they should be able to do it with some general accuracy. And what it came down to is they took a laser, they had it point at a specific target about 3 feet away, they turn their head, they reposition it, and they do multiple trials so you could get an average. And if you are in the ballpark, what they generally classified as roughly around 3.5 degrees, then you know that that person is doing pretty well. If they're measuring it off, then there's probably some deficits in their brain's ability to process that proprioceptive information. And one of the things that has caught my eye when I was looking into this stuff is that people have been looking at this since like the early 90s. And they actually tested it quite a bit in cervical trauma patients because they noticed that if you took a patient that had whiplash injury or a traumatic head injury, if you did a joint position error test, they were frequently missing the target by quite a bit. And that's where you start to have like, all right, this has some good validity data for it, that it could reliably pick out people that suffered a traumatic neck injury versus people that didn't. And you also had good reliability because if you repeated this test with different practitioners, you're going to get roughly around the same type of degrees of error with that individual patient. So, like, one of the big things for me is like, I want to know that a test is valid and I want to know that a test is reliable. So, this is checking both those boxes. Now, when you actually do this test, like we might not see that a lot of our patients have big joint position errors. And that's okay because this is kind of like in the realm of they suffered such a deficit to their proprioceptive system from a trauma that it caused it to be able to detect error at this level. We don't have the sophistication to detect very small levels of proprioceptive deficit. But nonetheless, especially if you are working with a concussion patient population, a whiplash patient population, I think this is a tremendously valuable tool to help us see what's going on, how the brain is perceiving the mechanical reception from the neck area.
And so
So,
speaking of that perception from the neck area, the tissues involved that we're talking about, we've got muscle spindles, right? And the various levels of layers of muscle in the cervical spine, flexors, extenders, rotators, laterally flexors, right? Muscle spindles in those. We also have the joint receptors themselves, right? So there's a variety of different tissues that, concurrently send that information to the brain, right? When you turn to the right, the left side muscles are doing one thing, the right side muscles are doing another thing. Right? That should make sense, to the brain, to your point, that when we're executing that movement, we're getting the appropriate feedback from all the associated structures, that there's a mutual agreement that this is the thing that is being done, right? And it's based on thousands and millions of repetitions of performing that movement, right? So it all becomes very very deeply ingrained. But when we're talking about like, okay, what are the receptors and where's that coming from? To your point earlier, it has nothing to do with the nerve root per se. It has a lot more to do with those other tissues that are invested with these mechanoreceptors, the joints themselves, the capsules, the ligaments to a degree, the tendons, the actual muscles themselves.
yeah, absolutely. And it's also one of the things that, we'll talk about in a lot of our neurology courses is it's also a test of how well is the brain integrating all of this information because we live in a multi-sensory existence, right? So it's also integrating, especially with this test, we're also taking in, how's their vestibular system integrating with the neck as well. So you're getting a global assessment of a lot of this stuff. And I like to compare it to like, VO2 max is this popular topic in fitness, right? And VO2 max is not strictly just individualizing, testing your heart contractility. It's not just strictly looking at your mitochondrial capacity. It's taking a global metric of all of those things. And it's kind of the same way with both this and your butterfly test, because it's saying how well does your brain take in all this information that tells us about where our head is in space? And is it accurately taking that information and making it useful?
Yeah. So there's input, there's processing, there's output, right? There's multiple layers of this. And for folks that maybe are a little uncomfortable with approaching, some of these assessments that don't seem relative to other things we think and talk about, you don't have to get to that. I guess my point is you don't have to get to that granular level to know that, it's the right scalenes are sending improper mechanoreception, which must mean that there's a listing associated with these attachment sites or anything like that, right? We don't need to correlate the laterality. We don't need to get too like weird about it. But to your point, there's a lot going on there. So we are assessing cervical spine function. That's the theme through this whole series, is how can we assess the different aspects of cervical spine function. So with range of motion, we're looking at movement capacity and control to a certain degree. With JPE, we're looking at that sort of position and movement sense. And this test is performed with your eyes closed. So we are sort of eliminating to some degree the variable of your visual fixation, or your ability to like utilize that visual stimulation or input to help correlate, right? So there's one less member of the band that member sitting this number out,
There
and
you
so we're
go.
relying a little bit more on those other systems, the integration, as it
For
were.
sure. So I got my screen shared. So if you're listening, turn on YouTube, put this on. And we're sharing the screen right now. You can see actually the range of motion report from NeckCare on this patient. So just to give you a little bit of background, this patient suffered a severe motorcycle accident. He required multiple surgeries in order to save his life. Like, the guy was very injured. So we're talking about, he got so injured where after he had all these surgeries, they saved his life. He basically spent 3 years borderline bedbound. Like, he was hardly moving at all. So just a little bit of context on that. So when we think about proprioception, we know that ligaments are going to transmit proprioception, muscle tissue is going to transmit proprioception. So there's a good chance that trauma is going to wreak havoc on a lot of these tissues. So just from the get-go, like, that's probably part of the picture. We also know that being bedbound and not moving your body at all, you're going to detrain a lot of your muscles, which will also give you a lot of this feedback. So this is the context of all of this. And we could see on this patient, he has extremely excessive range of motion. So I would be very comfortable saying this person is very hypermobile. So a lot to say that those ligament and soft tissue integrity is probably not providing that much feedback for this particular patient.
Yeah.
So now I'm going to pull up his.
And for the folks listening, we're looking at 102 degrees of left rotation, 127 degrees of extension. I mean, just beyond border 64 degrees of left lateral flexion compared to 26 on the right? So, we're talking about some extremes in terms of ranges there.
All right. So now we're looking at a chart of his joint position error sense. So if you're just listening, joint position error screen is basically going to have, like, if you look at a dartboard, you're going to have the outer ring of the dartboard is going to be colored in red. You're going to have the middle parts of the dartboard that's colored in yellow. And then you have the center part of the dartboard that's colored in green. So green, you're going to be within that 3.5 degrees of error. In the yellows, you're going to be somewhere in that 6 to 7 degrees. And then if you're in the red, you're going to be at beyond 7 degrees of error, which makes it, pretty abnormal. So on the screen, you could look at when he goes into extension, he has his eyes closed and he brings his head back to center. He is missing by an average of 14.7 degrees, which is a lot. We really don't see a lot of people miss that much. So every single one of his targets was way off to the right. He's actually kind of in the midline for like where in the sagittal plane, he's not too far inaccurate, but every time he moves his head up, his head is actually rotating over to the right and he's missing by 14.7 degrees. So right up from the get-go, when he moves his head into extension, he has no idea where the center of his head is in space. On flexion, so he bends his head down with his eyes closed, brings it back to where he perceives it as center. The average error was 8.3 degrees. He managed to hit the green zone once, but he hit the red zones and beyond the red zones twice, where they're not even, remotely close to the center point. And in left rotation, he has about 5.8 degrees, where he has 1 in the green, 2 in the red. And then right rotation repositioning, he has 1 in the red, 2 in the orange. So, generally, he's very inaccurate, but you can see that the large majority of his inaccuracy is stemming from going in the vertical sagittal planes. So what does it tell us? Well, just from this test alone, we don't know necessarily exactly what's going on. We just know that he has a very poor ability to detect where the center of his head is in space, which fits with this idea that he probably sustained severe ligament injuries into his neck, as we could see from his general range of motion. Mm-hmm. So now we have this idea is like, okay, he probably has a lot of cervical instability. He for sure has deficits in cervical proprioception, and then he has a corresponding severe history of trauma that kind of matches all of this together. Which, if you're building a case, especially if you're working with auto or litigation cases, like, this is a pretty like home run where you could say, yeah, this person suffered sustainable or pretty tremendous injury to his cervical spine. And from there, like, the good thing about this, despite the severity of his results, like, he has responded really beautifully to getting adjusted. Now, is his posture changing a whole lot when I adjust him? No. Is his, general range of motion likely to improve to the point where he's not like hypermobile? Probably not. But also, like, I am interested in seeing when we test this on him next week, like, how does his cervical proprioception, how's that feedback system working? Because, I've mainly just been adjusting this patient because he's been doing so well. And we could see, like, is his brain integrating the information that he has available to him better? Because from a neuroplastic standpoint, like, you don't have to fix all the tissues. You just have to make sure that the brain is able to use the information it has, and it has an accurate picture of the world around it.
That's a
This
great
reminds
way
me of
to put
that.
it.
You remember we used to use those GPSs like back before they were on our phones, the TomTom or whatever. And every so often you'd be driving somewhere where the map wasn't represented, and you would just see the car driving through empty space. And it's almost like this guy's like got no map. It's just driving through that extreme range of motion without an awareness of the surroundings, right? And it's interesting to think about like the correlation between, or the observation that with all of that extreme extension, it's the most inaccurate or the most unperceived in terms of accuracy of that movement. Kind of makes sense. Now, there's
Yeah.
like a couple of things I look for on this, and I don't necessarily understand 100% how to interpret it, but I always look for, is there obviously like a deviation or discrepancy, and is it consistent, right? Do you shoot close? Like, are all the darts hitting in the same area, just off the target, or are the darts all over the place, right? So he's got some that are okay and some that are way off. And it's kind of interesting to see sometimes there's like a consistency, right? Where there'd be like a lower left quadrant kind of a
Yep.
grouping where,
Yep.
okay, they may be off, but they're always off in the same way, right? What does that mean compared to someone like him where they're just completely inconsistent in all the different movements? Do you have any insights as to that?
Yeah. So if what we call that, like, what do we call that in science? So when we're looking at like reliability studies, when things kind of cluster together, like, they may not be valid, but we know that the measurement is reliable. It means that that brain is actually perceiving that the center of his head is off into this rightward plane. So then we have to kind of reverse engineer, is like, okay, why would he think that the center of his head is down and to the right? Is it a fact that he has this vestibular deficit or the lithic deficit, where it means like he's not getting feedback from one area, so his opposite ear is pushing him over towards that side, and that therefore he thinks that that's a center point? Is it a cerebellar type of a deficit? From a cervical spine standpoint, it's hard to like get a true assessment on that, but that's where you could try and kind of figure out, like, does he have like tight musculature on one side where it's actually pulling him towards that side? So those are all things that you might want to consider in the realm of possibility. But from my standpoint, my bias, I'm most often suspecting some type of vestibular deficit that is probably pointing him in one direction, since that has quite a powerful effect on like head repositioning when it comes to like rotating or turning your head. I don't have enough data to kind of say that for sure, but my suspicion, it's probably that, because one of the things I do see when I've been working with joint position error for a while is if I get the person doing head turns towards the side that they miss very pretty frequently,
Yeah.
we could actually start to get them creeping back towards center once they have a better representation of their inner ear going towards the side that they keep missing.
Yeah, it's
I'd be
interesting.
curious about the tone and to the tone of muscle, right? So especially on flexion extension, like what's the resting tone of the superficial posterior musculature relative to the anterior musculature, and then correlating that with what does the neutral X-ray or cone beam look like in terms of head position? Because this is, I mean, the fact that he's off in flexion extension, definitely and tremendously, definitely, at least in my opinion, is like, oh, there is a sagittal plane issue here. So if there was some sort of WOD or the motorcycle accident, like, was there some sort of flexion? Was the injury mainly in a flexion extension plane? Looking, and did it damage the posterior musculature more, or did it damage the craniocervical flexors more? Right? What does his head posture look like relative to a tilt and a turn? So SCM, That's funny that you're thinking all neuro, and I'm over here like, man, what are these muscles doing?
Yeah, sure.
Well, and I
It's
Sure.
thought of
That's
this
where
for
like my bias is there, right? So
yeah,
I thought
yeah,
of this for the range of motion portion. Maybe NeckCare 2.0 will involve some sort of surface EMG type of situation where you could actually measure some of that stuff and like what's your baseline tone and how does that fire off during these assessments. That'd be kind of
yeah.
interesting. But the
The
point being, there's a lot going on here, right? When you see this, don't overinterpret it. Like we talked about this with range of motion. If I'm a chiropractor, I'm adjusting people, I'm not doing all this neuro rehab stuff. You're going to want to just observe this, right? Like don't necessarily go outside the bounds of what you know you can do within your training and technique just because of this one assessment. Don't overemphasize like any one particular thing based on it. It's like we talked about with range of motion. Make observations, right? Measure, observe, gather data, just kind of see how you're doing with your assessments before you maybe overinterpret it or be quick to do something about it per se. Because as Dr. Chung and Bearder just alluded to, even folks with a higher level understanding of this than me, there's options, right? There's a lot going on with this stuff. So just keep it in context and make sure that it's just something you trend over time.
yeah, and like I said, like with this particular patient, I've only been adjusting him, and he's been doing really, really well. So when I retest this, and let's just say like it still looks like crap. It's like, okay, so we know that we're probably gonna have to work on other sensory systems if we want to improve this marker. But we're also going to correlate that with like, all right, how's he doing overall? If he's like very happy as a clam with his progress, we might not pound that neurological rehab with him too much because quite frankly, it might overstimulate him and it might make him feel a little bit worse. And he could be just perfectly happy with where he is right now, just getting adjusted. And if that's the case, I'm probably going to leave it alone and just keep it going at that, despite what the results on the test say.
Yeah.
But if he's like, I think, there's more to be had, like, especially when it comes to like, lingering brain fog and some other, kind of neuro-based symptoms, then yeah, we'll probably explore doing a little bit of vestibular eye head exercises and things of that nature. And, kind of take it from a patient-centered approach of like not just trying to chase the result on a test, but
Yes.
really like chasing what is in the patient's best interest for himself and what his goals are.
Yeah, love it.
Out of
when
curiosity,
you have done,
hold on. Out of curiosity, Chung, do you have a cervical MRI on this patient?
I don't. He basically just threw his history at me, and plus he had a lot of his imaging done overseas. Like he had the accident in another country, so yeah, he had limited accessibility to a lot of his stuff.
Interesting. That's the at a deeper level, flexion extension, some sort of fatty infiltration is probably in that upper cervical region in terms of atrophy
Oh,
of musculature.
without a doubt, just from
Yeah,
the the years of bed rest, really, I would say
yeah,
it's
yeah. Jeez, I
probably
forgot.
a given. Because
Wow,
like when you palpate his neck, like it is there's the tone is like there's very little like muscular engagement there. Yeah.
wow.
yeah, and that's a
Cool.
great point too. Like get hands on with people. Obviously, like we adjust, but feel this stuff. Like do motion palpation, do static palpation. Like get an idea of the tissues you're working with. And we did when I talked to Heidi Havik about this stuff. I mean, there is research on how muscle spindles change type, and how there is muscle tissue types change with
Mm-hmm.
deconditioning and with trauma and with
Mm-hmm.
injury, right? So these are all,
Collagen.
now mechanoreceptive issues. To your point about disafferentation, like this is one of the interesting things about like quote spinal manipulative therapy is the impact on stuff like that, and it has been researched and documented. So go back and listen to the episode we did with her. I'll link that in the show notes because there is a consequence to spinal injury, right? There is a consequence to spinal dysfunction when it comes to John's point earlier, your brain's perception and use of that like organ, let's just say. So there's a lot that goes into it, and it's obviously very complex neurophysiology. But again, the fact that we can measure it very accurately, very efficiently, without a lot of like monkeying around, with cumbersome tools, gives us at least a way to to test and measure and to track over time.
Yeah. Previously, when I didn't have NeckCare and I just did this all analog, like I would just take a global general assessment that, you know, accurate or not accurate. And like we could go and like I could have a staff member like take a ruler to it and do all these things. But you know, it is very logistically challenging to do that when you're in a practice that's pretty busy, right? So the ability to just turn the head, bring it back, and do it within 2 or 3 minutes is like it's such an invaluable thing. And like my staff does these tests and like we train on it and make sure that they're doing things pretty well. So I know like the type of data that we're getting is going to be good.
Yep.
And just
Yep.
experientially in general, like all of these assessments are experiential. Like the patient goes through the process, and so they perform this test with their eyes closed, and they go back to where they feel like they're neutral, and then they feel you reposition their head back to what's actually neutral, right? So even experientially, there is sort of this feedback that patients get going through the assessments that like, ooh, something's up here. Like I'm not quite there. You know, we're onto something. We're figuring something out here. And I think that's
Yeah,
valuable.
100%. Yeah, that's a
It
big
is.
one because like that's the most frequent comment that patients will give, and they're like, "Did I miss by that much?" Like, and they're like, "Yeah, well, yeah, we'll see what the data says."
Well, by
Wow.
the way, like we're talking, you know, like you said, 7 degrees, you're in the abnormal red range. Like that's not a tremendous amount of like, you know,
No.
degrees. Like you ortho people would freak out about 7 degrees of, you know, rotation or whatever. But in the human frame, right? We're talking about 7 degrees. Like there is a pretty tight, you know, there's a pretty tight margin on this stuff to like keep these systems in check, which is really fascinating. Like in just, you know, not getting too far down this rabbit trail, but just thinking about the fact that we freaking survive and that even in spite of the things that we go through, like what this guy's been through, the fact that you can feel better and that your life can progress and that the nervous system is always like seeking that homeodynamic position of like best fit for your environmental conditions you're in is a really
Mhm.
fascinating like testament to the robustness of the human in the first place.
Absolutely.
Have you guys done a lot of pre and post adjustment JPE assessments? And if so, what have been your findings or observations?
Um, as a re-exam, I have done it. When people have accuracy issues this bad, it does get pretty consistently better for sure. So for like my post-concussion patients, I do expect to see JPE get better because typically my post-concussion patients are missing by quite a bit. When it comes to like our probably normal day-to-day patient, if they're having like very small accuracy issues, it's probably not going to change a whole lot unless you do some more specific training for it. So one of the things that I do for patients that like have minor accuracy issues or even major accuracy issues, like I will actually do joint position exercises for them to help improve some of their accuracy, especially when they have that cervicogenic dizziness type or even just a regular general dizziness type. We'll use this as a way to give their brain different aspects of multisensory integration. So even like a patient with like vestibular neuritis, and I'm trying to select exercises to help do vestibular rehabilitation with them, I'm going to throw this into there because they are using some vestibular sense to try to reposition their head, and it's another way to give them a little bit of feedback onto that to help improve their performance on this type of stuff.
Yeah.
Pretty cool.
No.
Cameron, any thoughts on that?
Um. Yeah. I've done pre and post, and I have found it to largely be not consistent in terms of, you know, it's like, oh, people consistently get better or they consistently get worse, to the point where I've actually stopped doing post adjustment analysis, like immediate post adjustment. And I think that's a longer conversation. But what I do know is that Dr. Chad Beliris, may his DCCJP soul rest in peace, he is doing. I just have to poke fun, but he is doing and has been doing, I think, 6 months at least. He's been acquiring data and capturing data on pre and post orthospinology, upper cervical correction, and he's been doing using JPE as his main like pre and post immediate. And the preliminary results that he's shown me are actually pretty astounding to the point where I kind of question what I'm doing. Um, but I know I'm like, wow, he's getting it. But
Well,
Chad's
that
doing,
confirms Chung's
yeah.
Chung's theory that ortho adjustments are vestibular input.
Well, but like, and but Chad and I have had hours of discussion on this in terms of what could it be. And I don't want to give away his research because he's going to be publishing this, but like, quite honestly, it probably is more brain based than it is, quote, spine based. And I don't think there's anything wrong with that. I don't think that that should upset upper cervical chiropractors or chiropractors in general. That should get us excited. Like, well, shit, we're changing this, like we're creating neurophysiological change, not just moving the bones, as it were.
Yeah, those damaged joint capsules and those shredded muscles and like that stuff doesn't change post adjustment,
No,
right?
no,
So if it's firing off at a different frequency or it's being integrated differently and it's perceived as an improvement in head and neck awareness, that's pretty cool, and it
it's
isn't
huge.
necessarily, this is even in this pain science world of like, we get so fixated on end organ dysfunction and peripheral noxious stimuli, like trying to find the thing that is causing all the problems. Like sometimes that's not really that important, and you lose sight of the forest for the trees when you're looking for, which muscle spindle was it, and we have a bias towards specificity because we're upper cervical docs. And so we want to try to make sense of that and correlate it with, known efficacious things like listings. But at the same time, you don't have to. And again, like these things are not things that necessarily change overnight, right? Like that's why you can pattern it and follow trends over time. And even if you have a quote post that is clear, it's like for how long, like how long is that change sustainable? And that's where measuring these things at intervals over time. You guys had alluded to this previously, but 2 weeks, 4 weeks, 6 weeks, 8 weeks beyond, however you want to sequence it, have a system for reacquiring this data, right? Like don't just do this assessment to sell people on a care plan by telling them how messed up their neck is and not measure it and actually track progress over time. Gather these assessments, and to Chung's point, like it's the user friendly nature of NeckCare is that you can train a CA to get very highly accurate information with this stuff, and you don't have to be watching them over their shoulder and nitpicking over like the acquisition of data to know if you got something done right. So in that case, even more ways to make this useful over time. Any last thoughts on joint position error or sense? I know this is one that I think makes folks a little bit uncomfortable because they're not quite sure what to think of it and they're not quite sure what to expect with the testing over time. So any comments on that as we land the plane, as Cameron would say?
I think it's kind of like we said in the range of motion part of the test is like, don't take this as a test of subluxation. Like none of these tests in NeckCare, don't take this as a test of subluxation. Take it as one aspect of over global cervical spine health. And if you look at it in that way, then we're just presenting patients with this idea is like, hey, the health of your cervical spine based on your imaging is this, the health of your cervical spine based on these functional tests is this. And our job is to incrementally make these things better. And the adjustment is going to be part of that. So we're going to be measuring the impact of your adjustment in different ways. And it's going to improve some things, but it may not improve others, which means we might have to be doctors and recommend other things to improve your neck health besides just getting adjusted on a regular basis. So what does that look like? It might mean you have to do physical exercise. It might mean you have to improve your overall metabolic and mitochondrial health to improve the health of your brain. It might be all these other things to stack up because, going back to the previous example of like when someone has a medical condition, like if someone goes to the doctor and they have elevated cholesterol, like they might take cholesterol medications and that modestly reduces their cholesterol, but it's in the doctor's best interest, in the patient's best interest, if the doctor is also telling them, hey, cholesterol medication is going to get your overall cardiovascular risk factors down this small amount. In order for you to move the totality of things, you have to be exercising. You have to hit your 150 minutes of exercise per week. You have to get a little bit of strength training in to help the muscle metabolism. And you have to have a reasonable diet to get all these things because all of these things together will maximally improve your cardiovascular risk factors. And it's the same thing when we're talking about the health of the neck. The adjustment and the subluxation is one variable in the health of the neck. Where are all the other variables that we could pull on that are going to help improve the global totality of the health of the neck? And that's what NeckCare is really about.
Beautiful.
Love it. Yeah, and I think in today's day and age where data-driven processes and comprehensive management and like thinking through things at a level beyond the superficial is really valuable, to patients that have had disingenuous experiences in healthcare. This gives us a real nice opportunity to open the door to a lot of really important aspects of health in general via the neck that will enhance our patients' quality of life, their longevity, you could make an argument for, and also just their experience with chiropractic. So I think that's all really awesome. And, appreciate you weighing in on that, trying to demystify this particular assessment a little bit and give folks some context for understanding, where it might fit into upper cervical practice. But that's part 2. If you haven't listened to part 1, go back and check out what we had to say about the range of motion assessment, which Dr. Chung alluded to with this particular case. And then also skip ahead to sensory motor control via the butterfly test, which will be part 3 of this 3-part series. Check out the videos on the Atlas of Chiropractic on YouTube. Click the link there. I'm going to put the link for NeckCare so you can get us in touch with the team and do a demo. All that stuff's there. Thanks for sticking along with us through this 3-part series.